Do we have a question or two for the last two speakers before we open it up?
You see Triton and Cirrus different optic sizes with BMO. Did you check how do they align with each other? Because an important point can be not the size, but the BMO technique finds the center of the disk and puts the calculation ring according to it. So if the size is different, then they're just the size or just the center point will be different. Maybe you can look at it to see both the calculation rings put, both devices put the calculation ring into the same position, although they have different disk sizes. And it can be interesting to compare Triton with the Heidelberg device with the GMP new software, which has the more detailed optic nerve head analysis. Okay, thank you.
Thank you.
So to what extent could it be the centering, for example?
Sorry, I don't understand his
Oh,
question.
so I think one part of the question, at least, is to what extent could it be where you're putting the center of the disc? Was that a fair question? Is that? Yeah.
Both discs are aligned or different?
Sorry, we didn't compare that. And for Triton, we basically detect the disk margin points and calculate the disk center according the geometric center of that contour. And for ZEISS, we don't know how they calculate this information, and we haven't compared this information.
I have a question for Robert. Have you tried looking at patients before and after filtering surgery with dramatic lowering of intraocular pressure to see if there's a change in perfusion?
No, we haven't looked into that so far, but it's planned to do it.
Yeah.
Thank you.
All right, so let's open it up. Fair game, everyone. Yep. Rick, you still have a question?
I've been saving this one. I just have two things to mention. One, the Kyoko led a project, which I was a co-author on, where we looked at the lamina cribosa in high myopes. And curiously, they develop tons of dehiscences, and they never have a hemorrhage. But their circle of Zinnhaller is often stretched way away from the nerve, and they have peripapillary atrophy. So it's a kind of an interesting contrast in a high myope that maybe no Drance hemorrhages because there's no circulation coming into the lamina cribosa. Do you think that's possible?
Why don't you tell them about your study with the field first?
I don't know the answer to your question, so possible.
Thanks.
But you do have data indicating that in many patients, the field damage occurred first, implicating a structural insufficiency at the...
Well, I mean, the process of disc hemorrhage development is not de novo. I mean, it's not a... in glaucoma, the argument has always been, is it vascular or is it mechanical, right? So in glaucoma, the nerve fiber is lost, the topography of the disc changes, the laminar probably has a microvascular rupture, and you see a disc hemorrhage as a sign of glaucoma, just as you would see a notch or a nerve fiber layer. They don't just occur randomly around the disc, so they're occurring in areas of progressive glaucomatous optic damage, optic neuropathy. But to your point, I can't answer your question.
The second thing is more from Don's, two things actually related to Don's report. One is that you have that plus or minus 8 degrees for the macula.
Right.
That may change a little bit really if you think about how the patient tilts their head in the machine. But it's easy to pick out the macula just, you know, from image analysis. Why isn't the macula put pretty much in a precise location?
Well, the macula scan is being centered on the center of the fovea.
No, on your report.
The analysis is being used for this is based on the center of the fovea.
Okay. So
That's why that looks so great and has so few artifacts.
Okay.
Whereas when you're dealing with the wide field scan, you have to choose where you're going to center it, and if you center it on the disc, which is what we're doing at the moment, you're going to get occasional artifacts.
No, but see, in the wide field image, you could calculate just from the image analysis where the center of the fovea is in most patients.
Oh yeah, that's what we're doing. Sure.
Okay.
Yeah.
So that was.
Well, that's what Top Gun's doing. Yeah.
Yes. So
And that can be corrected. You know, if the algorithm gets it wrong at the machine, you can recenter it.
I see. The last question is, if you start with the OCT, right, not start with the visual field, start with the OCT and just use a Bayesian analysis, how useful really is a visual field?
Not, well, this will get us a debate going. I think the closest thing we have to a reference standard at the moment is the OCT. Now, this was going to be one of my questions to everybody else, so that if you wanted to detect early glaucoma in your mother or your sibling or somebody who's close to you, and you could only have one test. So at the moment, some people would say, well, I want the photo. Some people would say, I want the field. If you let them have two, they'd say the photo and the field. If I only could have one test, I would take the OCT. And in the studies we've done where we've followed up with the field, I change maybe 1% of my judgments based on the field. I just feel maybe more confident if I see the topographical agreement.
Can I tell you, just from a retina doctor standpoint, I'm not
Yeah.
a glaucoma doctor, retina doctor, probably one of the most underdiagnosed diseases we see is end-stage glaucoma. And then you call back the referring doctor and you say, this patient has bad optic nerve, the retinal nerve fiber layer is very thin. Their answer is going to be one of two things. The visual field is normal or the pressure is normal. Right? It's such a common thing to see.
And if you looked at the circumpapillary circle scan or our report, it would knock your eye out.
And other
That's
general,
probably a bad metaphor, but yeah, go on.
another general comment. The problem with glaucoma in the general population, not in filtered test populations, is all the false positive defects on the visual fields. The little branch vein occlusions, the AMD, a bit of diabetic retinopathy, and floaters and so on. So there are thousands of things that confound the visual field examination, and that's why I think structural analysis are going to win.
Well, glaucoma is highly complex when you think about the duration of disease exposure and where you're seeing the patient in the disease process. So there's the genetic predisposition, there's the intraocular pressure, there's the ancestry. That was my point earlier, that physicians looking at the disc are not very good. They're just not good at looking at the optic nerve and examining it. Sure, glaucoma specialist, pretty good at evaluating the optic disc. But the average clinician seeing patients rapidly does not screen very well for the disease process. Now, that being said, I personally think a disc photograph is critically important for every patient who has glaucoma because the technologies change. I've lived through OCT 1, 2, 3, Stratus, SD-OCT, swept source, polarimetry, all 5 versions, and none of them are forward compatible. So I look back at my disc photograph from 25 years ago, it still looks like a disc photograph.
But the difference is, though, you say they're not compatible because of the metrics that are involved. If you look at the retinal nerve fiber layer thickness, that's the same plot in all those machines.
Yeah, but the values change over
Yeah,
time.
the values change, but we
Right,
should,
so you can't
our argument
compare
is
them.
you shouldn't be looking at the values, and when you talk about photos, you're not looking at values.
No, so my point is that I think we've finally reached a technological level
Okay.
where we're able to look at so many components of the optic nerve from the lamina all the way to the ganglion cell. And when we integrate all of that information, when we integrate the BMO, when we integrate the ganglion cell complex, the RNFL, just as you're doing with your map, it will be even more sophisticated and be more sensitive and more specific.
Right.
So it will eventually replace things like the photo. However, I still think I like it to have a photo on most of my patients once, and usually I can get the retina guy to take a photograph of it for me. The question then becomes, do you need fields? And who should have a field, and how often should they have it? And I think we will enter a period of time when the frequency of field testing is going to diminish, at least for all these patients who are normal, glaucoma suspect eyes, or very early disease. We're much better off picking up disease change with the technology.
Yeah. Did the other clinicians want to, did you
Yeah,
want to?
so
Yes, go ahead.
I think, the other part we need to think about is the human factor. How do we convince a patient that they need to be putting a drop in every day in their eye for the rest of their life? And often if you show them an OCT scan versus showing them this is the part in your vision that you cannot see, often the visual field is more convincing. And it's certainly true for patients who are getting glaucomatous progression who need to undergo a surgery where they could potentially lose vision and not most likely not gain any vision, such as with trabeculectomy. And there, again, I do think that the visual fields and a series of visual fields could be very helpful in terms of getting patients to agree for those
Yeah,
procedures.
fair enough. Of course, one of our arguments is that if you look at the kind of report we're talking about, I can tell you where the field's going to be abnormal.
Sure you can, but I think patients want to know how they perform, right? It's their function.
Yeah, I have a question to Dr. Kroma. So you show that only temporal area is affected the tafluoroplasty treatment. And another question is, are there any relationship between lowering intraocular pressure and increasing blood flow? Are there any connection between two factors?
The second one, whether the blood flow is connected to the intraocular pressure. As we measured the patients only at one time, we can't really tell whether the blood flow changed. So we compared untreated patients to treated patients, and we can't tell if the treatment, the lowering of the pressure, did anything to the blood flow itself.
Why only temporal area was increased?
I expect that the superior and inferior area is changed as well, but we didn't match for visual field defects, and therefore it might just be in the small group that they cancelled both out because of the visual field defects highly correlate with the flow density in OCT angiography.
Donald,
Yes.
over here.
Okay, go ahead.
So I'm going to present this from a slightly different perspective as a high street optometrist in the UK, where we have a high number of people blocking hospital clinics. So I'm seeing 600 odd patients a month. And I've been using the Hood report and the 12/9 scan now for the last 18 months. So our protocol for assessing somebody who is a suspect, just a routine check that might turn out to be a suspect glaucoma, is we don't bother with full threshold fields. We use static super threshold multiple stimulus to identify just a gross defect. We use the 12/9 Hood report scan, we use our eye care tonometer. And that tells us really whether we need to go then looking for a 24-2 or maybe a 10-2 or whatever. Okay, so we have already moved to the paradigm of using the OCT as our primary presenting device, if you like. And that keeps patients in the primary care arena. They have no business having normal vision, getting anywhere near a glaucoma specialist. It's a complete waste of their time and whoever's paying for the actual service. So the second point I wanted to just add into that is that we have come across patients where, for example, we have identified a very clear nerve fiber layer defect, ganglion cell loss. We've identified them as having a 10-2 field defect. They've gone into ophthalmology, and they happen to have moderate to low intraocular pressures, and they're monitored without treatment, and nothing happens. So we don't even know whether it's a glaucomatous defect or a vascular defect at the disc. We have other patients who happen to be at the point of referral to have pressures maybe in the 24-25 area. They're put onto latanoprost because they've got a proven field defect and a proven OCT loss, and then they're monitored for many years later, showing no change in their status, but their pressure happens to now be 13. I don't think there's any way you can tell whether you've actually treated glaucoma or you're controlling it or not if you don't know what the causative mechanisms are. Sometimes I think we are treating stable glaucomas and they don't actually have glaucoma.
Let me speak to the first one. You want to speak to the second one?
Sure.
So I'll speak to the first, and Dr. Lehman will speak to the second. So if I understand what you're doing, it's close. It's in our recent review. It's what we were recommending in quotes, that you do the OCT first, and then you make your decision about fields.
Correct.
And the resistance we're getting has to do with a variety of things. I mean, one is just what people are used to. Another has to do with workflow and the way the clinic is set up. And then some has to do with billing and what you can bill for, depending on where you come from.
Correct.
He wanted to know about, but did you want to comment on the second question?
Well, the question of glaucoma pathophysiology is highly complex,
Yeah.
But I fundamentally think that it's fine to screen for disease with OCT, because you're screening not just for glaucoma, but we're also screening for macular disease. You could be screening for, poor image quality, could be cataract. So in a way, if you're going to do comprehensive eye screening for comprehensive disease, this is a way to do it. There is no, because glaucoma has relatively low prevalence, although high morbidity, there's no population-based screening method, at least, that's been proven to be
And I guess you could have added other optic neuropathies too, to the list.
Right.
In terms of, one thing I should add to the reports, in terms of comprehensive screening, we routinely look at the scan through the fovea. I prefer a high-resolution separate scan. That's what we routinely do. But if you just were doing one scan, you want to look at that through the fovea because you pick up macular holes, you pick up AMD, you pick up all kinds of problems that the glaucoma specialist didn't necessarily know were there.
Don, can you say something about region of interest and how we use a region of interest approach to diagnose and to monitor, perhaps?
Yeah. I wish I had a slide with me, but here's the bigger picture. The bigger picture is this is an incredible technology. We are so lucky to have this technology. It has 100 times the resolution of an MRI or a CAT scan. Yet, at least the glaucoma specialist often uses metrics, summary numbers. It'd be as if I had a tumor in my brain, and instead of looking at the tumor and measuring the tumor on an MRI, we had an algorithm do segmentation and red and green areas and summary statistics. You wouldn't do that. So the region of interest approach is just like you would look at the tumor. You look at the retinal nerve fiber layer, let's say, and you define the area at time 1 where there's an abnormality, and you just follow that. That's what you want to look at. I mean, you could take a metric and do an average number if you want, but you want to look at the edge of that. Is it moving towards fixation, for example, instead of looking at the average numbers? Is that
Right. A good example is perimetry. You have a normal visual field, and the visual field starts to change. The mean deviation of that field may be changing at 1/4 of a decibel per year. But the points that are changing, the region of interest that we're interested in, could be changing at 5 decibels per year, those 3 or 4 points. So we need to focus more on localized areas of interest on the OCT and in the field, rather than on, the global index, in which case the averaging of the global index causes us to lose a lot of valuable local information. And I think that that's one of the key messages from Don's work and from everything that everyone else has done here, is that the localized nature of the damage is now perceptible. We can now perceive the localized injury.
Yeah, I mean, absolutely. One of the things we've been interested in are these very common and often overlooked arcuate defects near fixation. We know from adaptive optics that those progress. We've watched them over a 9-month, 16-month period progress towards fixation. In a way, you can pick up on the OCT, and you won't even see on the 10-2. Now, you can ask clinically whether it's important, that amount of progression, but nevertheless, if that were my eye, that's what I would want to watch. I'd want to look at a decent OCT scan and watch what's happening over time.
I mean, clinically important is different than research, the importance in the research world,
Right.
or in a therapeutic target world. So for example, all glaucoma patients are getting worse. It's just a question of the rate, and to some degree, the location of the damage. But if you were designing a neuroprotection clinical trial, you'd want to do what you just described, which is I want to find the earliest possible damage, even if it's not clinically relevant, to rapidly screen neuroprotective agents or blood flow agents,
Right.
or other drugs. So I think that that's going to change tremendously, our treatment paradigms. We'll have a lot of new treatments available.
Another question here.
Short question to Dr. Hood. I'm lecturing in glaucoma OCT for a long time, and it takes a long time to people to teach T-SNET graphs. Now you have changing everything, and a lot of devices. It's I think a little bit confusing, even experts. So why don't you, that great report, not put T-SNET graph somewhere inside to people have something they used to for 12 years from the Stratus age?
Yeah. So I've done a lot of lecturing on this to optometrists and ophthalmologists, and actually the hardest people to teach are those who have been teaching it, right? And it's not old dog, new tricks. You know, I teach this routinely to 21-year-olds who do incredibly well at reading these things without medical school. Let me finish. And if I taught that 21-year-old to do it the other way, and she went out and taught people for 3 years, it would be hard to change, right? So I'm aiming at the rank and file. I'm aiming not necessarily at the teachers. I'm aiming, and that's been going well. And I have a series of lectures I'm about to put on a website through Columbia Ophthalmology that will be available to others.
I think part of our problem is that, you know, we learned a certain way. You know, we learned to look at the optic disc and look at the visual field. And in retina, you can look at the macula and you can see fluid, and you know, it's eminently visible and apparent, even on an intuitive basis. You know, the patients go into the room, they look at the monitor and they say, oh, I need an injection today. Right? In glaucoma, it's not so intuitive, and I think we have to reteach ourselves the process. The reality is, the macular region is where affects patients. It should be in the center of every scan. It should be the first thing we think about. I'm convinced that if we had to reinvent glaucoma today, we wouldn't do 30-degree visual field testing. We would start by doing a 10-degree visual field, because that's what affects the patient. And then only later on would we come back and do a 24 or 30-degree, 24-2 or 30-2 visual field. It's that we're caught in the historical trap that, you know, Von Graefe told his student, and that one told, you know, Dr. Becker in St. Louis. He told Dr. Rich, who was my mentor. Dr. Rich told me, and that's how I do it. But we have to stop that. We have to get out of the box that we're in and use the technology with the way it can be used.
Oh, okay, yeah, Charles, yeah,
Hi.
sure.
Yes.
You can have two questions, Charles.
Okay, actually, that's good because I have a clarification and a question.
Okay.
So, I'm Charles Reisman. I'm a co-author on Dr. Dong's paper here. And I just wanted to clarify, there was the question or comment about the disc center. So to our knowledge, the method that we used is not sensitive to where the disc center actually occurs within the disc. I think the point you raise is a good one for a follow-up investigation, potentially for where the disc center then influences where the circumpapillary circle or whatever other measurement is based off of. But the matter of where the center is shouldn't have affected the results in this particular study. And so then I also have a question for Professor Hood or whoever else might want to take a stab at this. I'm curious, what's your current thinking on OCT-derived simulated visual fields?
Yeah, so as you know, since we've talked about this, that we've done a fair amount on that. I think it's now, so the logic was the following. What we did was we said, well, let's take the OCT, you know, split it up the way into visual field things and use some fancy mathematics to predict what the visual field would look like, right? I think now with this topographical comparison, I don't think it's going to add much. I'm now convinced that if you look at the probability points on the field and the probability points on the OCT where it's red, and that's why I want to keep everything in the center, that the agreement between the two is remarkably good. And so I can look at that and predict what the visual field is going to look like and vice versa. But if I get the field, I just circle those points. Yeah, so I don't think, you know, even though we pushed that hard, I'm not sure there's a place for it.
I think it's a great research fellow project.
Yeah.
You know, because it would be interesting for a researcher.
And you could add it to artificial intelligence to see if it adds anything. You could do, you know, it could be
But the
part of
reality
that.
is, we have a good model already. We have humans. We can test them, and we can get the actual data. We can see if it, you know, it comports to that model and meets and is similar to it. But ultimately, I don't think it's going to change what we do.
No, yeah.